Hello and welcome to the website of the Queen's Healthcare Leadership Forum. I'm Adam Dolby, Chair of the Queen's Healthcare Leadership Forum, and welcome to part 3 of our Aspiring to Excellence series, exploring quality in healthcare. So in part 1 we looked at systems and system failures as well as the patient journey. In part 2 we covered the Francis Report and other NHS scandals. And now in part 3 we're going to explore the domains of quality in healthcare. So, an overview of what's to follow. We're going to look at dimensions of quality in healthcare and answer the question in that, what is quality? And then we're going to take a look at students' role in improving quality. And we're then going to summarise this excellence series at the end. So first of all, we're going to look at some concepts of quality. These concepts of quality that follow are not particularly set in stone. The National Health Service uses 3 main domains to measure quality: clinical effectiveness, patient experience, and patient safety. What this presentation does is expand on these areas, and just to give a little bit more detail about what each one could possibly involve. Again, quality is a bit more subjective than you might first think. What you regard as something that's high quality may be something completely different to what I regard as high quality, and the weight I put on certain areas may be completely different to the weight that you put on certain areas. You may prefer a healthcare service that provides high quality clinical effectiveness, whereas somebody who isn't necessarily medically trained probably doesn't understand what clinical effectiveness looks like, and indeed it's difficult for clinicians sometimes to be able to tell what clinical effectiveness looks like. So they may prefer 22-inch plasma TVs on the ward, or single-sex bays. So it's interesting to explore quality from the perspective of other people, as well as from what you view as high quality, as you need to achieve a balance between what other people value and what the professionals value, and how you provide that at the best cost. But we'll come on to that as we go through this talk. So the first area is efficacy, which is the ability of the science and the technology of healthcare to bring about improvements in health when used under the most favourable circumstances. So obviously this is limited by current knowledge. You can only provide the most efficacious care based on what you currently have, what the science and technology you have currently available can offer. Most favourable conditions, i.e. perfect conditions, are not always possible. So efficacy is always the ultimate standard that you're comparing against. It's always the benchmark quality. You can never get better than the most efficacious care, because that is the benchmark under perfect conditions. And it's not always easy to measure. It includes behavioural sciences where a model for measurement and comparison may not be available, i.e. you can't necessarily measure human behaviour. So overall, efficacy is about delivering the best available care based on current knowledge. So the next area is effectiveness, which is the degree to which attainable improvements in healthcare are, in fact, attained. So this is the degree to which efficacious treatments, which we've just mentioned, are the best quality treatment based on science and technology under perfect circumstances. Effectiveness is the extent to which they're achieved in real-world conditions as a percentage. So if you look at the graph that's shown on the slide, the blue line shows the health status of an individual with disease X over time if no treatment is received. The red line shows what happens to their health status if they receive the best care, i.e. the most efficacious treatment that's delivered under perfect circumstances. And the green line shows what you are measuring. So, in this circumstance, you get area A between the no treatment line and the assessed treatment line, which is the treatment that you're providing. And you get area B, which is the area between the assessed treatment line and the best care line. So obviously your assessed treatment is better than no treatment at all, but it's not as good as the best care available offered based on the best available knowledge and technology under the optimal conditions. So your effectiveness is therefore equal to A, which is the difference in the area under the curve between the assessed treatment and no treatment, divided by the total area A plus B. So therefore your effectiveness in this case will be measured as a percentage, and say that it's 50% or 75%. That will be the effectiveness of the treatment that you are offering under real-world conditions. So there's effectiveness as a measure of quality, the degree to which the improvements in healthcare are attained versus the most efficacious treatments under optimal circumstances versus the real-world circumstances. So your effectiveness is real-world, your efficacy is ideal circumstances. So just some notes on the previous graph. Note that the model represents probabilities and not certainties, so that death as an outcome in a single case doesn't represent ineffective care, because you just happen to have had an adverse outcome whilst providing high quality care, and there is a probabilistic chance that there will be an adverse outcome even when providing the best care available. Remember that not all information on health status may be available, and that health status in itself is a difficult thing to measure, and that with limited resources there may be two benchmark standards for comparison. So you may have efficacious treatment with unlimited resources, which is never going to happen obviously, and efficacious treatment with the limited resources available. So you may compare one of those with the other, and you may be better comparing the efficacious treatment with limited resources with your assessed treatment, rather than your efficacious care with unlimited resources when assessing quality with regards to effectiveness. Remember that the selection of your comparator is important in assessing quality, as it can have significant effects, and there can be significant difference if you use the wrong benchmark when assessing quality. Either way, that it gives you care that looks as though it's very high quality, or care that looks as though it's very low quality when comparing to the most efficacious treatment. So the next domain of quality is efficiency, which is the ability to lower the cost of care without diminishing attainable improvements in health. Remember that reducing the cost of healthcare does not necessarily reduce the healthcare improvements that you receive from a system. So, your equation for this is that efficiency equals the improvements in healthcare expected from the care to be assessed, divided by the cost of that care. So remember, to increase efficiency, you have to reduce the costs whilst at the same time increasing the improvements, or you increase the improvements from the same or a lower cost base. Remember that efficiency is related to the improvements that are affected. So simply by reducing the cost of care, you do not improve efficiency. You have to reduce the cost of the care whilst at the same time maintaining the level of improvements or even increasing the level of improvements in order to increase efficiency. So how do you improve efficiency? Well, there are three types of efficiency that have been listed here. So there's clinical efficiency, which is where healthcare practitioners implement care that does not include harmful, useless, or less effective remedies or methods. So for example, will that blood test, CT, X-ray, MRI change your management? And if it doesn't, don't order it. There's production efficiency, which is improving the way the hospital is run from a managerial perspective, so staffing levels, purchase of raw materials, etc. And finally, there's distributional efficiency, which is the provision of healthcare to those who are most likely to benefit from it. So for example, if you distribute healthcare to somebody who's really, really sick, they're more likely to benefit from the provision of healthcare than somebody who isn't really that sick. So the sicker somebody is, the more likely they are to benefit from healthcare, because by providing that healthcare you can treat low-lying fruit, like pain, fairly easily. Whereas if somebody really isn't that sick, doesn't have a lot of pain, not a lot of symptoms, it's more difficult to treat and they're less likely to benefit from healthcare. So you get a greater bang for your buck in people who are really sick than people who aren't at all that sick. Remember, of course, that there are ethical considerations to all of these aspects of healthcare. So do think about these as we go through the concepts of quality. So here's a case study of efficiency. Shouldice, they're a hernia repair centre in Canada, and they produce the best results at the lowest cost for that area. Literally, all they do all day, every day, is reduce hernias, treat them. So how is it done? Well, they have a production approach to services. So the building is designed such that somebody can walk into theatre, walk out to theatre, and recover in a nice environment, talking to other patients and being mobilised by a team of highly skilled, highly trained nursing staff who understand how to treat patients who've had hernia operations. So the staff are highly specialised, the buildings are highly specialised, and of course the surgeons are highly specialised in that the only operation they do is hernia repair. And interestingly, the patients are also selected. So it's not like the National Health Service where everybody has an access to it. Shouldice can select their patients because there's such a demand in their private healthcare industry that they can pick and choose which patients they treat. So their results are better than other hernia repair centres, so the morbidity, mortality rates of the surgery. But their patients are specially selected. There is a Harvard Business Review case study of Shouldice from the 1980s, if you wanted to have a look on Google and see if you could find it anywhere for those of you who are interested. But the overall lesson of this section is that you can improve efficiency and effectiveness simultaneously. So the next domain we're going to look at is optimality, which is the balancing of improvements in health against the cost of such improvements. And this is best demonstrated in graph form on the next slide. So this graph just takes a little bit of orientation. So the green line shows the benefits and the red line shows the costs. All you really need to consider with the top graph is that as the benefits increase, the costs increase. And the purple line at the bottom shows the benefits minus the costs. And let's just focus on the bottom half of the graph for now, because that's the important bit. So as the benefits increase, and as you go along the bottom of the graph, you get useful additions to care. And the graph slopes upwards, showing that the benefits outweigh the costs as the purple line increases in gradient. That's until you get to the first dotted line, which demonstrates optimally effective care. This is where the benefits and the costs are at their maximum ratio away from each other. As you go beyond that, the useful additions to care begin to decrease and the costs outweigh the benefits, but you are still providing useful additions to healthcare, but just in a less optimal way. So where the second dotted line is, you've got maximally effective care, which is the most efficacious care or the most effective care, depending on what your benchmark is. So on this graph, it's arguably the highest quality care is given where there's optimally effective care, if you're focusing on providing the most optimal care, i.e. you're only providing care to the point where the benefits outweigh the costs. Where you're providing care beyond that level, you could arguably be wasting money, wasting resources by providing wasteful care. But again, if optimality isn't the region of quality in your healthcare system that's important, such as in the United States, for example, that may not actually matter. It may not matter that you're providing maximally effective care instead of optimally effective care. You can not really describe the care as useless because you still are getting useful additions to care beyond the optimally effective care line. They're just costing more and the costs are outweighing the benefits. But again, this is a decision that has to be taken politically by consensus in the population as to where you draw the line. Do you prefer to have maximally effective care, in which case you'll have to be prepared to pay for it and pay for care where the costs outweigh the benefits, or are you only willing to pay for optimally effective care? Again, it's a decision that I'll just leave you to think about. So, benefits and costs. What do we talk about in the previous graph where I've mentioned benefits and costs? So examples of costs could be staff time, the resources used such as sutures, bandage, other materials, the fixed costs, the buildings, the rent, and can the costs even include opportunity costs? So an opportunity cost is where there is a cost incurred where an expense is incurred and money could have been better spent doing something else. So for example, if I want to start up a lemonade stall, my opportunity cost is of starting up a apple stall. I'll have decided that I could make more money from starting the lemonade stall than from providing the apple stall, for example. So I know that I'll make £10 a day profit from the lemonade stall, but only £9 a day profit from the apple stall. If I decide to set up the apple stall, my opportunity cost of not setting up the lemonade stall is £1 a day. So I therefore prefer to set up the lemonade stall. And the same example could apply in healthcare, but with healthcare products rather than apple stalls and lemonade stalls. But in healthcare, you can include the cost of the opportunity cost where you have made a decision that doesn't result in optimally effective care being provided. And that occurs where you decide to provide maximally effective care. Your opportunity cost of something else must be included in your costs. But again, that depends on your accounting method and whether you choose to include opportunity costs. Opportunity costs are economic costs rather than actual incurred costs. And at the end of this talk, I've put a good health economics textbook recommendation for those of you who are interested in health economics, opportunity costs and things. So the benefits. So we've discussed the costs, but what are the benefits that you can measure? So the benefits could be an improved health status, i.e. reduced symptoms, an improved length of life, reduced length of disease, improved quality of life, or quality adjusted life years, which I'll move on to now. So QALYs, or quality adjusted life years, are from the realm of health economics. And as I've mentioned, there's a good book recommendation at the end of this talk. So a quality adjusted life year is a way of measuring quality of life. So you can then get your measure of quality of life and divide the cost into it in order to receive a cost per QALY. They're used in the National Health Service by NICE, the National Institute for Clinical Excellence, and the cut-off point is thought to be around £30,000 per QALY. And I mentioned ethical implications of things earlier. The ethical implication here is that the National Institute for Clinical Excellence, NICE, value a human life at £30,000 per year. It's a very subjective measure applied to population samples, and I'll just demonstrate one of the methods that's used to calculate a QALY, just so you can see how subjective it can be. So this is the standard gamble. People are given a question of what probability of death would you accept given the choice between perfect health and having a disease. In this case, I've picked multiple sclerosis, and of course the people who participate in this will be given details of what that health state involves so that they can make a more informed decision. So they're asked to give a probability of perfect health they would accept, which in reverse gives a probability of death. So look at option A, the probability of perfect health versus death. So the option is a gamble between A and B. So given probability P, you end up with a probability of death of 1 minus P if you take the gamble and go for A. Or you can opt for B, which is certainty of you being in that disease state. So I'm going to go into some basic mathematics now and try and explain how you can get a value of P and a value of a health state from the standard gamble. So you find the probability P where people are indifferent between option A and option B, i.e. they can't decide whether they'd rather have A or B. They're indifferent to both choices. And that's the point where you freeze the value of P. So I'll use the example of multiple sclerosis that's given in the slide, but you could apply this equally to any other health state. So imagine that I am doing this experiment as a member of the public or a patient advocate or a doctor or any other member of the public, and I'm indifferent between A and B where the probability of perfect health is 0.25 or 25%. So I'm indifferent at the point where I have a 75% chance of death if I pick option A, i.e. 1 minus 0.25, or 100% minus 25%, giving 75%, and having multiple sclerosis. The fact that I'm willing to accept a high chance of death, 75%, suggests that I value the state of having MS, or whatever it may be in option B, as a low quality health state that I'm willing to gamble perfect health against death with a 75% chance of death. So taken the other way, if I would take a 75% chance of perfect health, probability P equals 0.75 or 75%, and the probability of death is 25%, i.e. 100% minus 75%, giving a probability of death of 25%. And I'm indifferent where probability P equals 0.75. It suggests that I value the health state B quite highly because I'm willing to accept a lower risk of death in my standard gamble, should I pick option A. So I've included the maths at the bottom of the page for those of you who are interested. The maths isn't actually particularly important, but the overall message is that probability P of perfect health is equal to the value put on the health state in option B. So P equals the utility, which is what economists measure as the pleasure that somebody gets out of something, of that disease state, is the same as probability P for perfect health. So, in the case where there was a 75% chance of death, and my probability P was 0.25 or 25%, the value of the health state of multiple sclerosis in that circumstance will be equal to P, which will be 0.25. And that, in a nutshell, is the standard gamble of achieving the utility, i.e. a way of measuring the quality of life, for a given health state. So methods like the standard gamble give you the utility of a given health state, i.e. the pleasure that can be derived from that health state, which you can equate to quality of life. You can then work out a quality adjusted life year for that health state for a given length of time. So the graph on the page shows that 50 qualities in two different ways, just to demonstrate that they're a function of the quality of life and the life years that are lived. So a quality adjusted weight of 0.625 for 80 years is equivalent to perfect health for 50 years, giving each 50 quality adjusted life years. So you can imagine that you can work out a quality of life weight for a health state with a given drug for a given length of time versus no treatment, in order to work out the quality adjusted life year cost and cost per quality adjusted life year of that treatment to improve that given health state. Now, of course, there are some other academic arguments that you can have about quality adjusted life years. So you could say that there is a health state better than perfect health, that can be valued at higher than perfect health. And arguably death as a health state of 0 may arguably be wrong. Some patients may prefer to be dead than to be alive in their current health state, and therefore their current health state may be less than 0, or death may be higher than 0 as a value. Take the recent cases of individuals who have gone to court asking for permission to kill themselves, or ask for a spouse or doctor to help them take their own life. So here are some more things to cover, just other considerations in the realm of optimality. Increased length of life from better treatments is a cost due to future treatments required, i.e. if they died you wouldn't have to pay for their healthcare for them, so you have to consider that in your costings. A quality of life may be reduced in extended life, and as we've discussed, qualities assume that death is the worst possible health state, which may not always be the case. Costs and benefits are discounted at a standard rate of 5%, and that's based on human behaviour, that you value something now higher than something you're going to get in the future. So the costs are discounted, either added to account for inflation. The benefits are discounted at a rate of 5% per year, as people would rather have improvements in quality now at this time rather than in 10 years' time. Ideal physicians consistently avoid useless care, Is this true of all physicians? Do you think you've seen examples of where doctors haven't avoided useless care? So have they prescribed antibiotics, whether it's clearly a viral infection, for example? And should cost be considered part of quality? This is the fundamental thing for you to consider. So the argument towards including costs as part of a realm of quality is that if merely useless care, which is care that is just useless, no clinical benefit whatsoever, is provided, it's socially irresponsible and demonstrates ignorance, carelessness, or inattention on behalf of the practitioner, which is of poor quality. It also wastes money and reduces the amount of money that can be spent on clinically effective care. So therefore I would argue, and academics in the field have also argued, that quality and cost should indeed be considered together. But make your own mind up about what you think and where you stand on including cost in a measure of quality. So another area of quality in healthcare is that of safety. So high quality care is safe care. Never was a truer word said. So remember, first do no harm from Hippocrates, and the importance of healthcare needing to be safe. The benefits must outweigh the risks of treatment at all times, and systems must be in place to reduce the risks of harm to patients that may be the result of delivering care within a complex system. So an example is the World Health Organization surgical checklist, which during the original research into the use of the checklist in operating theatres reduces morbidity by a third. For those of you not familiar with the World Health Organization surgical checklist, I'd have a look on Google for a start, just so you can have a look at the example of what the list looks like. But it involves stops of stop times just to check on the patient identity, the site of the operation, the patient allergies, just to ensure that obvious simple things have been accounted for, and that the wrong leg, for example, isn't chopped off. So quality care is also patient-centered. You need to view the patient as a customer, and the patient needs to have a choice in the service that they receive. And any improvements must have the consent of the patients. So how much weight do you put on this domain? Is it to the point where any improvements that are made to healthcare services must improve care for patients? Is that how patient-centered you're willing to be? Are all changes and improvements in healthcare affecting the patient directly? Are they directly improving the care for that individual patient who is sat in front of you, or those individual patients who are out there in the real world? So another domain, acceptability, which is the conformity to the wishes, desires, and expectations of patients and their families. So the whole healthcare system must conform to the social norms that are within that society where that healthcare system is based. So there are 5 aspects that I'm going to cover one by one. These are accessibility, the patient-practitioner relationship, the amenities of care, patient preference regarding the effects, risks, and costs of care, and what patients consider to be fair and equitable. So the first subdomain of acceptability is accessibility. So the distance from facilities. We've discussed in the previous talks in this series about centralizing services and how this could in fact reduce the accessibility of services given a lack of public transport or a poor ambulance service. So maybe the distance, physical distance from a service isn't that important, and indeed this area of quality has actually been put on the back burner a little bit in the National Health Service in order to improve clinical effectiveness. So this nicely demonstrates the balance that there is between all of these different domains in healthcare. Of course, the facilities must also be open to all and not discriminatory on any basis. So service must be available outside religious holidays so that you don't target a specific group by only opening when they can't attend for an appointment. They must be available outside working hours, and the services must be available in both rich and poor areas of the country, or of the town, or of the city. Remember that lapses in the accessibility of care can increase health inequalities within society. So the next area is the patient-practitioner relationship. So these are dependent on the personal factors of the practitioner. Stability, communication, the adaptation to the needs of the patient, maximum egalitarianism, empathy, rapport, avoidance of the exploitation of the patient, privacy, confidentiality, maintaining dignity, no discrimination. The presence of these factors are taken as high quality care by the patient because they understand those factors. They see them in the doctor and they think, yes, this person knows what he's talking about, he knows what he's doing, he's listening to me, he cares, he's good at communicating, he's always there for me, he's not always leaving and moving around general practices or hospitals, and he's able to respect my privacy and my dignity. I mean, he may be clinically useless, but the patient doesn't know that. So these factors are very important to patients. And you always hear about people talking about bedside manner when you start at medical school or you start at nursing school. People talking about your good bedside manner, because that's the side that patients understand and that they have an appreciation for. And interestingly, a poor patient-practitioner relationship is the most sensitive indicator of the persistence of differences adverse to the underprivileged in the organisation and delivery of care. So never underestimate the power of the patient-practitioner relationship. So the next part of acceptability are the amenities of care. And these are multiple properties, not all related to the technicalities of care, so the effectiveness, the efficacy. These are things that patients actually do notice, similar to the doctor-patient relationship or the healthcare practitioner-patient relationship. So these are the convenience of the facilities, the privacy, the restfulness, the cleanliness, the availability of car parking, the quality of the food, whether there are 22-inch plasma TVs all over the place on the wards. These are things that patients do notice. So, but do remember that a pleasant bedside manner, nice surroundings, quality food, good car park may cover up for deficiencies in the technical quality of care. And this highlights the importance of professionals acting as advocates to their patients and ensuring that high quality care is delivered. Because patients who are receiving care in a high quality environment that they perceive, because there's bedside manner, there are plasma TVs, good parking, good food, are not able to appreciate the fact that the technical care itself is of poor quality. And that's where the professionals come in as being good advocates for their patients and ensuring that the technical care is as good as the amenities of care and the doctor-patient relationship that's on display on the wards or in the general practice. Remember that satisfaction is equal to the reality minus the expectations. So the better the reality, the greater the satisfaction. But if patients have high expectations and the reality doesn't live up to that, particularly within this domain, they will not be satisfied. This is all about managing expectations, and that's why this area of care is particularly important, because they expect good quality food nowadays, they expect good available car parking, they expect them to be clean, the hospitals to be clean, and the staff to be polite. So patients have very high expectations, which means the reality has to be even higher in order to achieve good patient satisfaction. And remember that these high expectations are driven by multiple factors. So politicians, the media, friends and family, healthcare professionals who are their friends, all drive up these expectations. And when they see TV shows, they expect the quality of care that they receive to be just as good as is received on house, in theory. And they may even expect all the doctors to be as good looking as they are in Grey's Anatomy. That may be a measure of quality and an expectation. Do you think the National Health Service live up to that? So the fourth domain of acceptability is patient preferences regarding the effects, risks and costs of care. Remember that all healthcare medications, diagnostics, treatments, all have risks. And that both of these are weighed up by the patient and the practitioner. But the effects, risks and costs may be perceived differently by both. So it's important for the professional to have an understanding of the fact that patients may receive risk differently from the way that they perceive the risk of the procedure. I've met patients who think that they're going to be the 1 in 300 who has an adverse effect during a procedure because they've got bad luck, whereas the doctor says 1 in 300, this patient is just like any other. There are multiple causes and reasons that there may be different perceptions of risk, cost, and effects between the patient and the practitioner. One may be ignorance. The cure, of course, is education. And informative leaflets and websites such as NHS Choices are very useful in reducing in increasing the education of patients to reduce the differences in opinion between professionals and the patient. And there may be money considerations, and of course the cure that we found in the United Kingdom is with social financing of healthcare, or socialized medicine as the Americans call it. So they may have different, in the United States for example, this affects risks and costs may be perceived completely differently as it would be in the United Kingdom because the patient is having to pay for their healthcare. And remember that you must always take time to explain and consider the risks and benefits to the patient and ensure that they understand the concept of risk that they're taking on by undergoing a procedure or a diagnostic test or a treatment. And the risks, of course, are particularly important with modern investigations, modern diagnostics with regard to genetics. So you need to inform them that the result of a test may have adverse effects on their lives that you can do nothing about. So if they come back positive for Huntington's disease, what really are they going to do with that information? There's no treatment, there's no way of preventing it. It's just something hanging over them. So they need to consider that risk, and the practitioner needs to take time to ensure that the patient understands the effect of receiving a positive or negative test, in particular with regard to genetics, which is why there's an importance emphasis on genetic counselling before any genetic tests are provided on the National Health Service. So the final domain of acceptability, the subdomain of acceptability, is what patients consider to be fair and equitable. Patients have opinions about how they should be treated. Remember that every patient is different in their expectations, so it's can be very difficult to gauge what individual patients expect from their treatment. But of course, if you ask them, you might actually get an answer. Surprise, surprise. And these have to be balanced. These individual patient expectations have to be balanced against the needs of the population at whole. So even though a patient may think that what they're getting is unfair treatment because the National Health Service won't fund their boob job, for example, that is a decision that has been balanced against the needs of the rest of the population and the cataract surgery that needs to be done, or the cosmetic surgery on victims of domestic abuse or of violence that may need to take priority over breast augmentation. So another domain is legitimacy, which is the extent to which the healthcare system conforms to social preferences as expressed in ethical principles, values, norms, mores, laws, and regulations. And of course, this is different across countries and different across societies. Society has different measures of costs to individuals as it considers the whole. So it considers the opportunity costs of paying for an operation Y for somebody, where operation Z for somebody else may have achieved better value. So there's an opportunity cost in choosing one over the other. Society takes into account the externalities, etc., such as society pays more attention to wage earners because they're contributing to society, pays attention to the young because they've got more of their life ahead of them, so more years to add value to society. And democratic legitimacy is the only way of finding consensus on social versus individual burdens. So this is really one for the politicians. This is an area of healthcare that, yes, healthcare students and healthcare professionals can join in the debate on, but at the end of the day, it's a decision that needs to be taken democratically and is one area of healthcare that politicians can probably contribute towards. And they then draw up the regulation that is then in place that allows legitimacy to the rationing decisions that are taken within a public healthcare system. And so the final domain of quality is equity, which is the conformity to a principle that determines what is just and fair in the distribution of healthcare and its benefit amongst members of the population. So this depends on access to care and effectiveness and the acceptability of care. And remember that the National Health Service covers the whole population. And then you enter into a whole range of other debates, such as, in order to achieve equity, should the rich have to pay for healthcare so that the poor can get more healthcare out of the National Health Service? Would that be more equitable? So do you distribute healthcare according to the need or the social benefit from providing healthcare? Remember, there are huge ethical implications, and again, this is another region of healthcare that's decided by social consensus and the democratic process. So take a moment to think, are there any instances where the principles of quality that I've just discussed, the concepts of quality, have to be traded off against each other? So is there a point where you can think of where access versus effectiveness need to be traded off against each other? The amenities of care versus optimality need to be traded off? Equity versus effectiveness? Efficiency versus acceptability? Think about instances where those two dichotomous areas in each of those examples need to be traded off against each other. You can't have high quality in all of these domains, and that should be the main message of the areas of quality I've just gone over. There are trade-offs to be had between each of them. And the example that you could discuss is amenities of care versus optimality. So you could have high quality amenities, so you could have plasma TVs, really nice beds, individual rooms for patients with ensuite. Of course, that costs money. So you need to trade off whether those improvements in amenities of care are acceptable with regards to opportunity costs of spending that money on providing other forms of healthcare rather than providing pretty surroundings for patients. So the key points from this are that quality can be difficult to measure, but it can be done and quality can be improved. There's an old management adage that what can't be measured can't be improved. So just do bear that in mind. It varies between individuals. So individuals have different preferences on what they regard as high quality care. You need to apply different weights to different aspects in order to make the inevitable trade-offs that need to be made between the different aspects with the limited resources that you have. It covers lots of areas, different things, ranging from effectiveness, efficacy, safety, patient experience, clinical effectiveness, all of those different areas, including the amenities of care, the doctor-patient relationship. And organizations need to create a culture of continuous improvement where those who try and improve quality and strive to aim for high quality care are rewarded for doing so. And they're said well done to and thank you. Not necessarily financial rewards, just the satisfaction that they'll be listened to, the improvements will be done, and they'll be given the resources to be able to implement change and improve patient care and and service quality. So just take a couple of moments to think how you as a healthcare student can improve quality. So the domains are listed here. There's effectiveness, efficacy, safety, patient centrality, optimality, efficiency, acceptability, which includes accessibility, the doctor-patient relationship, amenities of care, patient preferences regarding the effects, risks, and costs of care, what patients consider to be fair and equitable, legitimacy, and equity. So think about these areas when you're on your placements. Think about each area and how you could improve that area on that placement. So to wrap up, how is this relevant to Francis? Well, quality improvement is highly dependent on the culture in which services are delivered. So if there's an environment where management and other leaders are encouraging quality improvement, then that quality improvement will happen. But if they're actively discouraging it, or even not really bothered about it, which is as bad as actively discouraging it, then it won't happen. Mid Staffordshire failed in multiple areas of quality. And Dunabedian, who's a quality assurance academic, said it is difficult, even impossible, for quality monitoring to be introduced and to flourish in a healthcare system or institution that is opposed to it. So just remember the importance of culture in improving quality in healthcare and the importance that Francis put on quality improvement and the culture that surrounds quality improvement and that's required in order to improve quality. So the foundations of quality assurance, these are just from the academic literature. The requirements of quality assurance, are a genuine commitment to quality where everyone at all levels in the organisation is proactively looking to improve quality. There's an institutionalization of that commitment in the form of institutional goals, allocation of resources to improvement, provision of leadership to support achieving those aims, design and implementation of a formal system of monitoring and communicating information, creation of a culture towards quality assurance, and an agreement on the meaning of quality. So they're the three areas that are required in order to have the foundation of a culture and a quality assurance in a healthcare organisation. And the bits I've highlighted in purple are actually referred to in the Francis report as well. So Francis actually matches the quality assurance literature. So we already were aware of the lessons that Francis had taught us, but maybe we need to pay a little bit more attention to the quality assurance literature in order to ensure that professionals are doing the members of the public justice. So here's just a slide on the steps in monitoring and improving performance, just given us for those of you who may have an interest in how it's done on an organisational scale. So you determine what to monitor, first of all. You then determine your priorities in monitoring, so which areas do you want to focus on when you're monitoring. Select an approach to assess performance. Formulate criteria and standards, obtain the necessary information that you need to measure performance, choose when to monitor, choose how to monitor, construct a monitoring system, and then bring about a behavior change, which is about leadership, which is covered in the first of our video podcasts. So on a smaller scale, there are PDSA cycles for service improvement or quality improvement. And students can do these. We hope to have some on our local experience network at some point in time, so anyone wishing to submit any possible projects that lend themselves to a PDSA cycle will be most welcome to do so. So PDSA stands for Plan, Do, Study, Act. So the first stage is plan, so you determine the objectives, make predictions, plan how to carry the cycle, and plan how you're going to collect data on your improvement. Next you do, so you carry out the plan on your improvements, record the observations, and then record the data. You study, so you then analyse the data that you've collected, compare the results of what you've changed with what your benchmark was and what the previous performance of the system was, or the process, and then you summarise what was learnt. And then the act. So what changes can be made on a wider scale? These studies are done on a small scale as little mini trials that can then be escalated should success be noted. So what changes can be made on a wider scale? Is behaviour change required organisation-wide? And then you need to consider the next PDSA cycle. So it's a continuous improvement. There's a reason that there are arrows going to all four of these boxes in a circle. Quality improvement is a continual process. So in the words of Don Berwick and his report into safety in the National Health Service that was released in August 2013, I quote, "While zero harm is a bold and worthy aspiration, the scientifically correct goal is continual reduction. All in the NHS should understand that safety is a continually emerging property and that the battle for safety is never won. Rather, it is always in progress. And I would argue that the same applies for quality improvement." So let's bring to a close this three-part excellence series. We first looked at systems and system failures, the importance of analysing system failures, either through Reason's three-bucket model or the Swiss cheese model. We also looked at the patient journey and centralisation of services. We then looked at the Francis report into what went wrong at Mid Staffordshire, the importance of culture in particular in preventing it from happening again. We also looked at the recommendations, including openness, transparency, candour, minimum standards and core values within the system. And then we also had a look at what role students may have in ensuring that something like mid-staffs doesn't happen again. And I hope that you all do remember Francis when you see a patient in bed and think whether their dignity is being respected. And then we looked in the talk that I've just given at quality, the many dimensions of quality that there are, the fact that it can be difficult to measure, and that there are lots of social, ethical, and moral implications of improving quality, and the trade-offs that have to occur between the different domains. And finally, we just had a look at a PDSA cycle. If you Google PDSA cycle, you'll find lots of examples of good PDSA cycles and how to do them. So if you're interested in having a look, you may also contact us about our local experience network that may have further information and opportunities for you to carry out your own PDSA cycles. So thank you for listening. I hope you found the 3 parts of this Aspiring to Excellence series useful, interesting, and informative. And I hope that you continue to attend future QHLF events. You can join our mailing list at healthcareleaders@qub.ac.uk to find out about further events, or even to join the committee. We have a multidisciplinary committee with nursing, dentistry, pharmacy, and medicine all represented, and we're willing to represent any group with an interest in healthcare from any department within Queen's. You can find us on Facebook. You can follow us on Twitter at QUB Health Leader, or you can visit our website and explore further the Queen's Healthcare Leadership Forum at www.qhlf.co.uk. Thanks again for listening, and I hope to see you at future QHLF events. Don't forget, you can also look on our website at the Local Experience Network for experiences in medical leadership and management, as well as service quality improvement projects. Thank you.